So hello friends and welcome back to my channel. Today I'll be discussing about the second part of Kawasaki disease. In the first part I have already discussed about the pathology, the epidemiology, the etiology, the lab findings and some of the clinical manifestations of Kawasaki disease, and in this video I'll be discussing about the diagnosis, the differential diagnosis and about the treatment of Kawasaki disease. So let's start. So first, starting with the diagnosis. So the diagnosis of Kawasaki disease is based only on the clinical signs first. So it's based on the clinical signs, and now let's talk about the criteria of diagnosing the patient. So fever should be present, which is persistent, as I have already discussed in the first video. Those who haven't watched, I'll give the link in the description box below. Just watch the first part and then proceed to the second part. So fever which is present for at least 4 days and which is persistent, we can say, and which is not responsive to antipyretic. Okay, so fever plus, so 4 out of 5 characteristics, the clinical characteristics which I'll be mentioning below. So at least 4 out of the 5 characteristics have to be present for diagnosing the patient. So the first is changes in the extremities. So as mentioned earlier, there are two phases in the Kawasaki disease. So I will talk about the changes in both the phases, the acute and the subacute phase. So in acute phase, erythema of palms, soles and edema of hands and feet is seen. Edema of hands and feet. These changes disappear when the patient is progressing towards the subacute disease, the subacute phase, sorry. So in subacute phase, you can see the periungual peeling of the fingers, desquamation we can see, which is a very common word used in this disease. So of fingers and toes. So the second change is the polymorphous exanthem, which is the polymorphous rash, is the characteristic rash. The third is bilateral bulbar conjunctival injection. This is a very important finding. So this has to be without the exudate, and this feature mainly allows us to differentiate it from the other diseases. Okay, so the fourth change again is the erythema and cracking of lips. You can see red eyes and cracked lips, red lips, and obviously the cracking of lips, dry lips. So also strawberry tongue, which is a very important distinguishing factor in this disease, strawberry tongue. Then there is erythema of oral and pharyngeal mucosa, The fifth is the cervical lymphadenopathy. So it is mostly unilateral and the diameter should be more than 1.5 centimeter. So as mentioned earlier, 4 out of 5 characteristics should be seen, and fever for at least 4 days, which is persistent and non-responsive to antipyretics, is the diagnostic criteria. But a very important thing I have to say here is that these features, they don't occur simultaneously, they don't occur together. So these features don't occur concurrently, which means that sometimes not all the features are present when the patient comes to you. Sometimes only polymorphous rash may be present, and fever and changes in extremities and erythema, but not sometimes the oral and pharyngeal mucosa. So that is the difference when the patient comes to you. So that means that these features don't occur simultaneously, these features don't occur concurrently. So moving to the differential diagnosis, so I will tell you how to rule out other symptoms, other diseases, and to rule in Kawasaki disease. Okay, so first I'll be talking is measles. So obviously measles have fever and rashes, but I will only talk about the diseases and the distinguishing factors, the distinguishing symptoms, distinguishing features to rule them out. Okay, so first is measles. Okay, so in measles obviously there is fever and rash, but also there is the exudative conjunctivitis, then there is Koplik spots, there is rash on the face, hairline and behind ears, and there is, okay, that's all. So this is the features which allows us to differentiate measles from Kawasaki disease, because there is the erythema of palms and soles, edema of hands and feet, and most important, there is bilateral bulbar conjunctival injection which is without exudate, and in measles it is with exudate. So this is one of the very important symptom which allows us to differentiate it as measles or Kawasaki disease. Okay, so moving to the next. So next is adenovirus. Okay, so again in adenovirus there is exudative pharyngitis and exudative conjunctivitis as well, which again allows us to differentiate it from Kawasaki disease. The third is Rocky Mountain spotted fever. Okay, so here in Rocky Mountain spotted fever patient, myalgias are seen, then there's headache at onset, then there is centripetal rash, and there is petechiae on palms and soles. Okay, so again this is very different from Kawasaki disease. The fourth I will be talking is leptospirosis. I'm so sorry for the disturbances. So leptospirosis, basically this is a biphasic illness. So there are two phases with asymptomatic days. Initially there are some asymptomatic days. So what all is seen here is actually I have to say in two phases. It's in the initial phase and then the late phase. So in initial phase, headache and fever is seen, and in late phase there is hepatic and renal failure. Okay, so the fifth is toxic shock syndrome. So again, renal insufficiency is seen, coagulopathy is seen, pancytopenia, and inflammation of the muscles, that is myositis, is seen. So these are some of the diseases which are similar to Kawasaki disease, but the distinguishing features allows us to differentiate it from Kawasaki disease. Moving to the next, about the treatment. So for treatment of Kawasaki disease, so let's talk first about the acute phase. So in acute phase, 2 gram per kg of IVIG is given to the patient. So there is the single infusion of IVIG. So how is this administered? It is administered over 10 to 12 hours and within 10 days. Okay, so this is given the most important treatment, that is of the IVIG. Okay, so what else is given? So plus I will write as moderate to high dose of aspirin is given. Moderate to high dose of aspirin. So how much is the moderate and high dose? So moderate dose is 30 to 50 mkd divided every 6 hours, and the high dose is 80 to 100 mkd divided every 6 hours. So aspirin and IVIG is given in the acute phase. So one important point I have to tell it here. So other NSAIDs are then not given, should not be given during this period when aspirin is given. So other NSAIDs should not be given. Why? So obviously because they can block the action of aspirin. So other NSAIDs are avoided. Okay, so the next point. So the dose of aspirin before is either 30 to 50 mkd or 80 to 100 mkd, that is the moderate or the high dose, but the dose of aspirin is later reduced, is decreased, is a better word, is decreased to literally 3 to 5 mkd. So why this is decreased and when this is decreased? So why and when it is decreased? So I'll answer the question when. After the patient is afebrile, when the patient is not having fever anymore, then this dose of aspirin is decreased. So after the patient is afebrile, the dose is decreased, say about 14 days, 2 weeks. Yeah. So why this dose is decreased? So it is first dose which we have given is the anti-inflammatory dose, so it is decreased from anti-inflammatory to anti-thrombotic. Okay, so this dose is therefore decreased. So before the dose is either before the dose is either 30 to 50 mkd and or 80 to 100 mkd, but later it is decreased to anti-inflammatory to anti-thrombotic when the patient is afebrile. So some important points I have to discuss more apart from the treatment. So when there is aneurysms, so either it is the moderate sized or the large sized aneurysm. Moderate sized or the large sized aneurysms. So when it is the moderate sized aneurysms, the dual antiplatelet therapy is given. Dual antiplatelet therapy is given, and when it is large size, it is anticoagulation with either warfarin or low molecular heparin is given. With aspirin obviously is given, with aspirin, because aspirin is continued in the patients having aneurysms. So this was the first important point I had to discuss. So second is about the vaccination. So patients undergoing the long-term aspirin therapy, so the patients, they are undergoing long-term aspirin therapy, so the patients receiving the long-term aspirin therapy, so they should not receive the annual influenza vaccine. So they should not receive the annual influenza vaccine, because this reduces the risk of the Rayet syndrome. To reduce the risk of Rayet syndrome. Okay, so third important point, so MMR vaccination is again not administered. MMR vaccination should be deferred, until 11 months. 11 months after the IVIG administration, actually after IVIG administration. Okay, so this was the third important point, that the MMR vaccination should also be deferred until 11 months after the IVIG administration. Again important, so the non-live vaccination do not need to be delayed, only the live vaccination is delayed. So non-live vaccination need not to be delayed, so only it is the live vaccination which is delayed. So this was about the important points. I have discussed the treatment, the differential diagnosis, and the diagnostic criteria of Kawasaki disease. So like the video guys, if you really like it, subscribe to my channel, share, and now you can also follow my Instagram page. I will give my Instagram handle. So study club is also now on the Instagram, so it is by the name of study club. So follow study club on Instagram for more details, more clinical pictures on the diseases and also the MCQs. So every week we'll be discussing about one disease, the clinical pictures of that disease, the MCQs, and other important points. So thank you, that was all.